Well, I want to welcome everybody to our Kindred at Home Clinical Grand Rounds. This is Lila Thomas, National Medical Director for the Southeast region. I'm happy today to introduce you all to Chaplain Hank Dunn. Chaplain Hank Dunn received his Master's of Divinity from Southern Baptist Theological Seminary in Louisville, Kentucky. He's been a chaplain since 1988. He worked in various healthcare arenas and became a hospice chaplain in 1996. In 1993, he wrote and published Hard Choices for Loving People and Light in the Shadows. In 1990, he was first published The Hard Choices for Loving People, CPR, Feeding Tubes, Palliative Care, Comfort Measures, and the Patient with Serious Illness. It is now in its 6th edition, and it has been published. There have been over 30.5 million copies that have been sold to more than 5,000 nursing homes, hospices, faith communities, and hospitals nationwide. As I said, it is also now available in Spanish, Chinese, and Japanese. Today, Chaplain Dunn will be our guest speaker. He's been a guest speaker at numerous national events and conferences, and it's our pleasure to introduce Chaplain Dunn. Please go ahead and talk about your topic, helping patients and families with end-of-life decisions.
Well, thank you, Dr. Thomas. I'm very glad to be here. This has obviously been a subject very important to me over the years. I started as a nursing home chaplain right after the state of Virginia passed the Natural Death Act, and our nursing home was a 200-bed, for-profit, family-owned nursing home, and the owners said, well, what are we going to do about this now that the Virginians have this in the law, a right to refuse treatment, a right for an advance directive? And they said, well, we're going to tell everybody about who comes into our nursing home about their choices, and Hank, we want you to do that. I was very new in this, and so I started reading and, of course, talking with doctors and nurses, and so I developed these ideas about helping patients and families with end-of-life decisions from a very early time. So today, in this hour, I want to try to talk about these things, these 5 things, as we go through the lecture. I want to talk about what I see as the main issue patients and families struggle with. And then I'm going to talk about goal setting, the importance of goal setting first before we talk about anything else. What are the 4 most common decisions that patients and their families have to face? Then I've developed 5 questions that I give to patients and families to help them make these decisions. Will form the framework of our largest part of our lecture today. And then finally, I'll look at some of the emotional and spiritual issues at the end of life. I had an incident when we talk about what the main issue is. I had an incident that happened. I had been a nursing home chaplain for about 10 years when this happened, and it has become a metaphor for me for understanding these decisions with patients and families. And what happened was, I came into the nursing home. It was a Monday morning, and one of our volunteers came up to me and she says, Hank, I've got to make a life and death decision about my mother by Thursday. And she started to cry as she's telling me this. So I said, well, let's find a place we can talk. So we got some privacy. And I said to her, well, tell me what's going on. And she said, well, Mom is in a hospital down in Virginia Beach, which is about a 3-hour drive from where we were in the D.C. suburbs of Virginia. Mom's in a hospital in Virginia Beach, and she's on dialysis. And my brothers and sisters and I have to make a decision whether to take her off dialysis or not and let her die. And then I said, well, tell me, what about her condition? Has she all of a sudden gone into kidney failure, or has she been sick for a while? So, she's been sick for a long time. She's had 2 strokes in the last 2 years, and then, of course, now her kidneys are failing, and it's been a long downhill slide for her. And then I said, well, what do the physicians say? Is the dialysis doing any good? And she said, oh, they don't think it's doing any good at all. And then I said, did your mother ever give any indication what she would have wanted done in a situation like this? And she said, oh, yeah, Mom said she never wanted to be on dialysis. And I'm thinking, what's wrong with this picture here? And I said, Jerry, this is not a hard decision. I said, of course you take your mom off dialysis for all the reasons you just gave me, that this is the end of a long decline in her health. The physicians say it's not doing any good, and your mom said she didn't want to be on it. And then I said, what's going on here that makes this so difficult? And at that point, she started to cry again. She says, I think I'm feeling guilty because I haven't visited mom enough. Well, when she said guilt, I knew she was moving into my area. I'm a Baptist. I know we Baptists like to think we have more guilt than the rest of you guys, but of course there's a famous Catholic guilt and equally famous Jewish guilt. But I knew it was a spiritual, emotional issue that she was dealing with, and we did talk about that and about her understanding of what was going on with her personally. And like I said, this became a metaphor for me for understanding that what is the biggest issue that people deal with when they deal with these end-of-life decisions. So I've developed what I call Hank's theorems. These are things I think are true. I don't necessarily have the research to back it up, but it's just based a lot on my experience. This particular one, though, there is a lot of research that looks at patients and families and what their decisions are. And here's the theorem. For patients and families, end-of-life decisions have little to do with medicine, law, ethics, religion, or morality. For them, the decisions are almost wholly emotional and spiritual in their nature. Now, do these decisions have anything to do with medicine? Well, of course they do. It's a huge part. This woman was on dialysis. She's in a hospital. A doc had to order the beginning of the dialysis and will have to write an order to stop it. So, yeah, medicine's a really big part of it. What about law and the ethics and morality? What's legal? What's ethical? What's the moral thing to do? These are important, and I think the medical team surrounding these decisions are going to help patients and families stay within the law, within ethical standards, and what the morality is. The religion, then when I say has nothing to do with, little to do with religion, I say religion as opposed to spiritual, as you see in that last sentence. Religion and affects some people's end-of-life decisions. A great example, of course, is the Jehovah's Witnesses. We know Jehovah's Witness will refuse blood transfusions, even if it means they would die without the transfusion. So their religion has a huge impact on their decision. But most people, their religion doesn't have that much to say about these particular decisions. But the emotional, spiritual issues being things like, what's going to happen to me when I die? What's going to happen to my family? What's been the meaning of my life? These questions everybody deals with. And so those decisions, the emotional part, like, for example, what I just gave you, this lady feeling guilty, the guilt was driving the decision of whether they withdraw dialysis or not. So that's, I think, is the most important thing that people are dealing with, and we'll come back to this throughout the lecture. These are should be of surprise to nobody, but the decisions that most people have to face, or that you'll see more often, of course, are what about CPR? What about artificial hydration and nutrition? This might even have to do with IVs and people in dying patients. What about hospitalization of nursing home patients or assisted living or people living in their own home? And finally, when do we shift to a comfort measures only or palliative care or hospice toward the end of life? So I want to look at briefly at these four decisions. But the place we always have to start before we get to these particular treatment decisions is the possible goals of medical treatment. What is the goal here? My first summer as a hospice chaplain, on a Monday morning, I had two voicemails waiting for me when I got to the office. One was from a social worker, and another was from one of our nurses, and the voicemails were almost exactly the same. They said something like this: Hank, we have a new patient. She's come in over the weekend. She's been in the hospital. She was on a ventilator in the hospital. They were able to get her off her ventilator, but she does have a feeding tube, and now she's at her daughter's home. And the daughter's saying she wants everything done to keep her mom alive. Back to the hospital, ventilator support, CPR, whatever it takes. She wants everything done to keep her mom alive. Can you help us? And of course, I called them both back and said, I'll do what I can. So I made an appointment. It was Wednesday before I got out there to visit with the patient and the family. And when I got there, the patient had been moved to a recliner chair in the basement, the family room of this daughter's home. She was alert. She would track you as you walked around the room. She looked at you. She did not was not reliable in giving, at least for me, giving yes or no answers. Of course, I was, as in my role in chaplain, I was there to kind of do a spiritual assessment and see what the spiritual needs of this patient and family were. So we talked about that, and the daughter answered all the questions, although the mother seemed to be paying attention to what was going on. So in my role as chaplain, what I typically do, I would offer to have a prayer, and they said yes, they would like to have the prayer. So we held hands. It was me and the patient, the daughter, and the son-in-law, and I had a prayer. And as I was saying goodbye, I said to the daughter, I've got a little booklet out in my car I'd like to give you if you could follow me out. So I wanted to give her copies of the booklet I had written, the Hard Choices book. And I started in on her. I was trying to talk her out of doing CPR, of calling the rescue squad, and that our medical director really recommends a no CPR order for all these patients like her mom. And she listened, and she was kind of patient with me, and she interrupted me eventually, and she said, all I want is for my mom to die peacefully here at home. And I said, we can help you with that. That's what hospice is all about. But dying peacefully at home takes a lot of planning and preparation. Usually it's ending up in the ICU, that's the accident, ending up on a ventilator or other types of life support. And we can help you with that. So she said she wouldn't call the doctor and to get a do not resuscitate order. And I left, and I felt like I'd done a pretty good day's work just helping her sort through these things. And I got back to the office, and there was a message from this daughter. She had called, and I called her back, and she had one question for me. How long does it take a person to die if you stop the artificial feeding? Well, I didn't even touch the artificial feeding issue with this patient, the family, because I thought, well, we just made one step, and that is to get the do not resuscitate order. But I told her what my experience had been. I'd worked with a number of patients and their families who had withdrawn artificial feeding, and it's a very peaceful death, and her mom could have that peaceful death at home. The daughter said, okay, well, I'll tell you what, my brother's coming over on Saturday. I'll talk it over with him, and if we feel okay about it, we'll talk it over with Mom and see what she would want to do. Well, Saturday came, and Sunday came, Monday morning, I get the newspaper out, and lo and behold, this lady had died on Saturday. So I called to wish condolences to the daughter, but I also wanted to find out what happened. And so she said, well, we got her up like we usually do, and she was in a recliner chair, and she's listening on the phone to her grandchildren, her brother's children, and they were singing to her, and her breathing just slowed down, and she died right there. So the point is that this daughter really set the goal. I was trying to talk her into a particular treatment plan that is a no CPR order, and she said, all I want is for my mother to die peacefully here at home. So this is the place to start. We talk about goals. In any conversation we have with patients and families, this is the place we want to start the conversation, to be able to establish some realistic goals for the patient. And then the professionals, the doctors, the nurses, that can help the patient, if possible, to achieve the particular goals that are reasonable for them. This list of goals, Dr. Carol Taylor, who is a PhD bioethicist at Georgetown, helped me with this list a number of years ago. And I like it. It's short, and it kind of summarizes possible goals of medical treatment. First, of course, would be cure. You get a upper respiratory infection, your doctor prescribes an antibiotic, you take it, you're cured of that particular situation. Maybe we can't cure something, but we can stabilize functioning. A good example of that is diabetes. We have no cure for diabetes, but people can live for a very long time with a very good quality of life, with medication, proper diet, exercise, and never be cured, but stabilize their functioning. Well, maybe we can't stabilize functioning or cure someone, and at that point, it might be time to prepare for a comfortable and dignified death. Now, of course, you can kind of mix and match these things. I've had a number of hospice patients who had stopped chemo and radiation. They were preparing for a comfortable and dignified death, and then they got pneumonia and chose to have antibiotics to cure the pneumonia. You don't also necessarily have to move 1, 2, 3. A lot of times people have been trying to cure, again, let's say cancer, and realize it's not working, and they move to preparing for a comfortable and dignified death. This is important. I think, the research, there's a lot of research on where people would choose to die. Most people say they want to die in their own home, and yet most people actually die in hospitals. And so if we can help them identify what the goals are, and if we do get to that point of preparing for a comfortable and dignified death, we can maybe help them get to their place where they would most want to die, if that is what their goal is, to die peacefully at home. Just let me look real briefly at CPR, and this is one of the first of the 4 most common decisions. There's been a lot of research into CPR, at least for 50 years. It was first developed in the 1950s and 60s, and the research started coming out then. The average survival rate of those hospital patients who get CPR really has not changed much in this 50, almost 60 years of research into CPR survival rates. On this slide here, you'll see the people that are most likely not to survive CPR. We don't, by the way, about 17% of the people will survive CPR, and the survival is defined as being alive when they are discharged from the hospital. Of those 17% who do survive, we do know at least half of those have brain damage, everywhere from being in a vegetative state to mild cognitive impairment. But we do know ahead of time those who will not survive. Those will be included the multiply diagnosed patients, those who have more than 1 or 2 medical problems, those who do not live independently. This would be all your nursing home patients, the assisted living patients, people living in their own home. These people we know don't survive just because of their debilitating illness that left them unable to care for themselves. And lastly would be anybody with the terminal phase of an illness. This, over the 50-something years of research on CPR, really hasn't changed. It's these 3 categories of patients who we know ahead of time before you ever start the CPR will probably not survive. I was surprised. I wrote the first edition of my Hard Choices book as a nursing home chaplain, and the subtitle of the book was for nursing home residents. And this was in 1990 that the first edition came out. And I was surprised that hospices were buying them by the boatloads. I was ignorant enough. My world was mainly nursing homes and occasionally visiting our nursing home residents who went to the hospital, but I had very little experience with hospice. So I was thinking, people go to hospice and they've already made the decisions about CPR. But as you know, many have not at that point. And so what CPR becomes for so many people, we know who these types of patients who are not going to survive, yet sometimes patients and their families might ask for CPR, even though the chance of survival is slim to none. And it becomes just a symbolic gesture. I have many times been in an emergency room going with residents of nursing homes to the hospital after being rushed out from the nursing home with CPR being performed on a relative, and the doctor comes out from the treatment room and tells the family that we tried, but we were unable to save the life of the patient. And often the family says, "Oh, we never gave up. Dad was such a fighter." And so it just becomes a symbolic gesture. So on CPR, let me just summarize with a couple things to remember here about CPR. If the patient and family are requesting CPR when there is no reasonable medical benefit, then find out the core issues and address them. When I'm talking to clergy groups, This is what I tell them. If a family member, one of a person in their congregation says that the doctor is asking them to decide about CPR for their mom, and they don't know what to do, and if they're struggling with the decision, I tell the clergy, you just assume there's some pastoral care issue if they're struggling with this for a patient in those categories that we know that won't survive. And I say, you don't give medical advice, but just ask them, how's your relationship with your mom, your dad? Is there anything that is left undone between the two of you? Are you feeling guilty about anything? So those are the issues that need to be addressed when the patient or family is requesting CPR and there's no reasonable medical benefit. This would include, too, of course, the patient themselves, because I've had patients who are very debilitated, no chance of surviving CPR, but they say they want it. And I've said to them, this is such an unusual request for someone in your condition. Can you tell me more about that? And so they would go into some of the emotional, spiritual issues that they're struggling with. And secondly, things to remember. Do not attempt resuscitation, DNAR or DNR, whatever your facility uses, or no CPR does not mean do not care. And this is what families and patients hear sometimes. When you say do not attempt resuscitation, they hear do not care. So we always need to assure the patient and the family that we will care for them, clear their airway, give them oxygen, give them pain medication, whatever it's necessary to keep them comfortable, even though we're not going to beat on their chest and try to start their heart. Let me move to these questions that I've developed over the years. I started with the first edition of my book with 3 questions. It's now grown to 5 questions, which I've had since 2001 with the 4th edition of my book. But the first question is, and these are questions I give to patients and families to help them make this decision, what is the agreed upon goal of medical care for the patient at this phase of life? I like to use the term phase of life. We reserve the word dying for the last hours, maybe days of a person's life. But if we were to say, would you say, and I say this often, would you say your mother is in the last phase of her life? And most people know that you're on a downhill slope for a lot of frail elderly people. So they would say, oh yeah, she's in her last phase. So helping them with the goal, and we've already talked about that a little bit, the setting goals. The second question is a question I'm actually going to change. I have used this now from the first edition of my book. I had this question, what does the patient want? But I have been influenced by an article, which I want to share with you right now, that helped me rethink this question. This question is presented mainly to families often. Well, what would your mother want to do? Just like I had said to my friend, did your mother ever give any indication what she would have wanted done? So the article came out last year, but I've just recently become aware of it, and it's had a great influence on me because I'm actually going to make some changes to the Hard Choices book because of this article. The article is, you can't get what you want. Innovation for End-of-Life Communication in the Intensive Care Unit by Dr. Margaret Swartz and her colleagues. They said that this question, what do you want, or what would the patient want, is really a bad question. We need to shift the question. And they went into the article and gave 3 reasons why the want question is not really helpful. The first reason they gave is that it encourages the family to reflect on treatments like life support or comfort care rather than on goals. Like this first story I started out with, or the story about the goals, I was trying to convince the family not to do CPR. I was talking about treatments. And fortunately, the daughter shifted and she said, all I want is for my mom to die peacefully. The second reason why this question, the want question, what would your mother want, is not helpful, is that can shut down discussion. Once the family makes a choice, what else is there to say? So when someone says, oh, mom is such a fighter, of course she wants to live, do everything you can to keep her alive, there's really not much else we can talk about. So if we can move from the want question to some other question, it might be more helpful. The third reason why it's not helpful is want is aspirational and evokes fantasies. When we ask patients or their surrogates what they want, we release the constraints of the decision-making context and allow consideration of possibilities outside the boundaries of the clinical reality. You know, when you say, what would your mother want? Well, Mom wants to get back into her gardening. And the reality is she's not going to do any more gardening in the situation she's in now. She will not be able to get back there. She might be alive, but she's not going to be able to continue what she had been doing. And this is where, of course, physicians, especially and other healthcare professionals, can help patients and families assess that. So if you don't use the want question, what would your mother want? What would you use? And the people, the authors of the article went on to say, let's explore what would they think about their current condition. And these words here, actually, we're reprinting the Hard Choices book this month, and we're changing that question, what would the patient want, to this question. What does the patient think about their current and probable future condition? And I go on to explain it. A patient with decision-making capacity can speak for themselves. If they are unable to express an opinion, then try to imagine how they would think about the state they find themselves in. If the likely outcome of further life-prolonging procedures would lead to increasing disabilities and/or greater mental decline, what would they say about that? The purpose of this question is to try and imagine what the patient values most. I had a personal experience with this question several years ago before I read this article, and I don't know why I didn't think about changing my question at the time. But what happened was my mother was in hospice care out in Colorado. We had moved her from Florida, where she had been in an assisted living place, and moved her to a memory care unit in Colorado, a bit close to my sister. She, at this point, then was getting more frail. She could not walk without assistance. She needed help for dressing, eating, toileting. She did still know us, did seem to respond, but very little verbal cue or very little verbal interaction with her. She fell and broke her hip, fractured her hip. We didn't even send her out to the emergency room. They sent in a portable x-ray and verified that, yes, indeed, she had fractured her hip. As soon as she fell, I knew it was not going to be long, a week or two before she was dead. So I flew out to Colorado to be with my sister and with my mother. The day after I got there, flew out there immediately. We met with the physician, Mom's physician, and his first question to us was, what did your mother think about her dementia? Now, here we are talking about my mother, but I'm, of course, a healthcare professional too, and I ask these questions all the time. And I knew my mother was going to be dead within a week or two. But when the doctor said, what did your mother think about her dementia? I thought to myself, what a great question. He wanted to know what my mother thought about her condition before the fracture of her hip. And Mom hated her dementia. She talked about it when she was a little more lucid. I don't like what's happening to me. She threatened suicide on a couple of occasions because she didn't like what was going on with her. Without asking anything else to us, the doctor then said, and we explained, my sister and I explained, she just hated her condition. She hated what she was like. And the doctor said, okay, here's what we're going to do. And he told us what the plan of care was going to be. He did not even mention that we could send her out to the hospital and have a hip replacement, which could have been done. But he said no. He didn't say no. He just said, here's what we're going to do. And we'll give her pain medication. We'll keep her comfortable. And so this is what now I'm shifting this question to, this second question. What does the patient think about their current and probable future condition? This leads us, of course, to questions of making decisions on behalf of other people. This is surrogate decision-making, substituted judgment, family decision-making. I have a couple of my theorems that came up as I thought about these families making decisions for patients. This one has two parts to it, one this and a corollary. It goes like this. Families who withdraw treatment from patients without decisional capacity always say something like, I know this decision is what my mother would have made for herself. I have always heard families say something like this, that they are assured that what they're doing is what the patient would have wanted. And conversely, families who have visited a decision about withholding or withdrawing treatment that would allow a natural death, but decide to continue, often, not always, but often say something like, I don't think I could live with myself if I ordered the withdrawal. And one other of my theorems that has to do with family members making decisions goes like this. And there is a lot of research on this one, by the way. The ability to let go increases as the emotional and geographical distance between the family member and the patient decreases. We know, as difficult as it is, it's easier for a spouse to make a decision about a spouse than the children or the cousin or the second cousin or the court-appointed guardian. So the closer we get to the patient, the closer the family member is to the patient, the ability to let go is a lot easier. Not that it's easy, but it is easier. We see this term in the medical literature occasionally, the daughter from California syndrome, or the folks out in California call it the daughter from New York syndrome. And we all know how that works. There's, a couple children, and there's the daughter out in California, and she flies in at the last minute as they're trying to decide whether to withdraw treatment and let the patient die peacefully. And she says, oh, I love Mother so much, we can't let her die. And it's like, where have you been for these last years that I've been taking care of my mother? So as family members are closer to the patient, the ability to let go tends to be a little bit easier. It's not always that way, but often it's that way. So we do get into substituted judgment. And by the way, this next one too, we get into of kind of regional differences. What is in the best interest of the patient in light of the chosen medical goal? This one, you'll find out it is very subjective, because one people say it's in their best interest to keep them alive at all costs, and other people may say, oh, they would not want to be kept alive on machines. It's in their best interest. So it's very subjective, but it also has to go with the regional, what's going on in the region. And I'll show you something on feeding tubes in just a minute about that. Fourth question is, what are the prognosis and probable consequences if a certain treatment plan is followed? This is where physicians, especially nurses too, can really help. Me as a chaplain, I can maybe quote some statistics, but I have to point patients and families to discussing probable prognosis and probable consequences with physicians. So this is where physicians especially can be very helpful in patients and families sorting through this. The last question is, if these answers to these four questions point to withholding or withdrawing treatment, then the big question is, can I let go? Which gets back at what I said is the most important issue for patients and families, is letting go at the end of life. Let me just give you a couple more tips here on these people making decisions. This is something I tell to patients and families often, and more often it's families than patients, more often than families. And that is, you can never make a wrong decision. You just do the best you can with the information you have at a time. You might look back months from now and say, we made the wrong decision. We shouldn't have kept Mom on the ventilator. We shouldn't put the feeding tube in. But you didn't know that at the time, is what I tell patients and families. You did the best you could at the time. So it was not a wrong decision. So you can never make a wrong decision. You just do the best you can with the information you have at the time. Let me just point you to a YouTube video. If you were to Google best case, worst case, whiteboard, either on YouTube or just Google it, you'll come up with this whiteboard presentation. Dr. Schwartz, I got in touch with her after I read the article and dialogue with her about changes I was going to make to my book. And she said, and she suggested this was something they have done up at the University of Wisconsin of a way to talk to patients and families about end-of-life decisions, of doing best case, worst case scenario. So this is a presentation by a physician. It's 11 minutes long. It's something you can watch in just a very brief amount of time, and gives you the basics of how to talk to patients and families. One of the things Dr. Swartz also gave me information too, the idea of talking about scenarios, helping patients and families see the possible different scenarios. You can do this too with a traditional benefits burdens. You just take a sheet of paper, put a line down the middle. On the left side, you put the benefits. On the right side, you put the burdens. You write the treatment towards the top to do CPR on a particular patient, and then the benefits and the burdens. And then you do another sheet of paper or lower on that piece. The other treatment possibility is to withhold CPR and the benefits and burdens of each of those. So these types of things can help patients and families as they make end-of-life decisions. So let me go into talking briefly about artificial hydration and nutrition and some of the decisions that people are faced with that. I will say, as I talk, and when I have more time and I give a longer lecture, I might talk a lot more about this artificial hydration and nutrition, but I always start with this slide. Feeding tubes, of course, can be very beneficial to many patients. There's stroke patients who use it just temporarily, throat cancer patients who may even live for years who are successfully treated with their throat cancer but never swallow the end of a feeding tube. IV fluids or feeding tubes do not quench thirst. A lot of times people would say that to me if we're sitting vigil around a patient who's dying and the family says, you know, Mom hadn't anything to drink. Should we start an IV to keep her comfortable? The answer is no. The ice chips in the mouth, sponge swabs, there's a lot we can do to alleviate the uncomfortable symptoms of dehydration, the dry mouth. You'll hear me say that dying is an indication, stopping eating is an indication that the end of life is near. Well, not always. There could be other reasons why people stop eating, and we might need to explore those. The choice is not necessarily between artificial feeding and no feeding, but between artificial feeding and careful hand feeding. I've heard it said to people at nursing homes especially, but, you know, your mom's having a hard time swallowing. She's going to starve to death if we don't put a feeding tube in her. That's not true. These patients can be fed. It's very difficult, but they can be fed for a very long period of time. I won't take much time on this. This is just, and you can, but the different types of eating difficulties that lead to this questioning or consideration of feeding tubes. There's been a lot of, this is a summary of research that is on patients who are dying without artificial hydration. So this will be your dying patients who are choosing, or their families, or they are choosing not to have IVs for hydration. They might have IVs just to keep a vein open for pain medication, but at least we're not hydrating them to be fully hydrated with the IVs. So there's all kinds of benefits. There's less fluid in the lungs, therefore less congestion, less fluid in the throat, less needs for suctioning. For patients who have tumors, there's less pressure around the tumors, and less pain, less fluid going in and less coming out, less risk of decubiti, less fluid retained in the patient's hands, feet. The patient's just more comfortable. And as you know, there's natural pain-relieving chemicals that are released as a patient dehydrates, and therefore you have a more comfortable death. Let me say just a few things about dementia patients. I used to spend a lot of time talking about this, but actually I have a little bit of good news. And the most recent research is we as a nation are using feeding tubes, artificial feeding tubes for advanced dementia patients a lot less than we did just 15 years ago. This was a study that looked at the use of feeding tubes. This is the actual insertion of feeding tubes within a year of someone being diagnosed with advanced dementia. For all patients, it's gone down from 12% in 2000 to 6% in 2014. There is a racial difference for white patients from 9 to 3%, for black patients from 38 to 18%. And this goes back to what I said about best interest. Some of these decisions are made when what you might make the same decision that was made for Aunt Susie or my uncle or whoever was dying. They got a feeding tube, so we're going to do the same thing for my mother. This is an old chart, but it probably bears out today. This is the use of feeding tubes throughout the country. The darker states have a higher incident of using feeding tubes. The lighter states have less. Urban areas tend to use feeding tubes more than rural areas, so you can kind of see that in how it's spread out here. And I already mentioned about white patients and black patients. So the point is this, that a lot of times the medicine doesn't drive these decisions. It's driven by what is done in your own region. There was a couple years ago, and they keep adding to this, by the way. If you were to Google choosing wisely, you'll find, I think there's up like to 70 different groups now, but what this group did was they asked different physician societies to recommend 5 things to question. In other words, maybe this is not the right thing to do. For 2 of these groups, the American Geriatric Society and the Hospice and Palliative Care Docs, these 2 groups, both recommended their number 1 recommendation is don't recommend percutaneous feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding. So it offers no benefit to the patient, and fortunately, probably, like I said, we're seeing a lot less of this. Patients, as I mentioned, when people stop eating, it's a sign that the end of life is near. This was an article from a number of years ago. Christopher Justice had gone to India, where people were moved to this one town. It was better spiritually to die in this town. And he asked the family, "Well, how do you know when to bring the dying person to this town so they can die?" And he said, and the answer was, when they stop eating. The family recognized that the cessation of eating is a sign, not a cause of dying. They classify an old person as dying when they stopped being interested in food. So let me just summarize this section on feeding tubes and artificial hydration. Things to consider. One is a time-limited trial. Sometimes we don't know how well a person is going to do. A stroke is a good example of that. And maybe let's try a feeding tube for a little while. But time-limited in that, a physician can recommend maybe in a certain amount of time, we'll go and revisit this issue. If the feeding tube is accomplishing what we would hope it is, that is a bridge till they can swallow on their own, then maybe the tube can come out. But if the patient, after that period of time, is still in a non-responsive state, then the patient, the family, or for the patient might be choosing to withdraw treatment. Time-limited trials can be used for all kinds of things: ventilator support, dialysis, hospitalization, antibiotics, and we'll try it for a little while. If it works, then good. If not, then we're not going to keep doing it. Second thing, dying without artificial hydration promotes a peaceful death. We talked about that. About dementia patients, it doesn't do them any good, so we won't do that. According to ethics in the law, if a treatment can be refused in the first place, then it can be withdrawn. I don't hear this much anymore, but at one time I've heard people say, "Oh, we could have chosen not to start the feeding tube, but now that they have it, we have to keep it in." So anything that can be refused in the first place, according to ethics and the law, can be withdrawn. And lastly, and this is important, withdrawing treatment is not killing the patient. The patient is dying from the pathology which rendered them incapable of eating. I had a patient one time in the nursing home. She was in a persistent vegetative state. She had had a brain tumor and they were operating on her, had a bleed on the operating table. By the time they stopped the bleed, she was left in a vegetative state. And she was like that for a couple of years. And the physician who was caring for this patient, who knew this patient and family well, it was a family physician, he said to the family, "If this was my daughter, I would stop the feeding and let her die." The mother came to my office one day, and in tears, she said, "If I stop the feeding, will I be killing my daughter?" And I said, "Of course not. She is dying from this brain tumor, or at least the bleed on the operating table. You have Nothing to do with the fact that she's dying. The timing maybe, but not that she's dying. I had a patient one time who was on dialysis. He was a very devout Catholic, and he was deciding to withdraw dialysis or not and just die peacefully in his nursing home bed. And he asked to see me. So I went in to visit with him. We had many visits, and like I said, he was a very spiritual, very devout Catholic. He had one question for me. If I withdraw the dialysis, will I be committing suicide? I said, of course not. You're dying from kidney failure. If you never started the dialysis, that's what they would have said. He died of kidney failure, and that's what they will say about you after you die. So, and he did stop that feeding and died a peaceful death there at the nursing home. So, moving on from that, third most common decision that people have to face is whether to put somebody in the ICU or into the hospital or not. This was I was feeling crazy one day and came up with this my first of my theorems, and it goes like this: the peacefulness of a death is directly proportional to the distance from the hospital ICU. I mean, a lot of people will say, if most peaceful death would be in my own home with my family gathered around me. If that's not possible, then maybe in a nursing home or assisted living with my family there and just keep me comfortable. If that's not possible, then in the general ward of a hospital. And a lot of us would say the least peaceful death is in the ICU, where we're hooked up to machines and there's, tubes going in and out every orifice of our body, and then at the last minute, bells and whistles go off and they beat on our chest. I was speaking in Vermont one time, and I showed this slide, and a woman came up to me afterwards, and she said, I have to take an issue with that slide you showed. And she said, I'm an ICU physician in rural Vermont. It's a small community hospital, and we use the ICU as the hospice inpatient unit, and we have many peaceful deaths. And I had to agree with her. I've seen many peaceful deaths. The point of in the ICU, the point of the slide is the death in the ICU where people are hooked up to machines is what we would usually consider not the most peaceful death we could have. These are burdens of hospitalization. You can look on the PDF that have these listed. This is especially hard on nursing home residents, other confused residents, if they're used to their surroundings, either in their own home or in the assisted living or in a nursing home. It can be really hard on them. Increased use of restraints, all kinds of reasons why. So obviously sometimes people have to get into the hospital, but there's other ways we can treat patients. When I started as a nursing home chaplain in 1983, we didn't even have IVs run in nursing homes. If you had an IV treatment, you had to go to the hospital. But that, of course, has changed now, and you can be treated with IVs in a nursing home or in your own home. I throw this in just to talk about other treatments can be withheld. Antibiotics is a possibility. A lot of times families are choosing for PVS patients, for persistent vegetative state patients. They couldn't bring themselves to withdraw the feeding tube, but they can say if they get pneumonia, let them die a peaceful day. Same thing with advanced dementia. So the last treatment to look at of the 4 treatment decisions is where most of you in Kindred are working with, and that is for hospice and palliative care. I like to show this slide. It's kind of confusing. It's big, but it's old, actually. My friend Joanne Lynn, Dr. Lynn, she got this slide from her, and this is an algorithm about the care of evaluation and care of patients with heart failure, and it's a typical algorithm. You do this, and this decision tree, and you finally end up in the right-hand corner toward the end of the disease, which I'm going to blow up here, and you see you go continuing medical management, good outcome. Well, then yes, then you follow up. If no, additional pharmacological management, more drugs. Are they candidate for transplant? If yes, then you refer to a transplant team. And no, watch what happens. They come around again. Continuing medical management, good outcome, no. Transplant, no. You keep going around this circle. And wouldn't it be wonderful if we had in this chart, and fortunately these charts are being changed as well as medical textbooks. That is, there's nothing we can do for these patients to keep them from dying, but we can keep them comfortable. And we can treat all these symptoms that makes heart failure uncomfortable, which brings us back to where we started, that is preparing for a comfortable and dignified death. I have this in here. Since all of you are working with hospice and palliative care, I don't really need to spend time on talking about palliative care and hospice care, But it's important, of course, to explain to people the difference between the two and the similarities, that we really are trying to alleviate all the symptoms. There's been a lot of research on this too. As you know, palliative care patients actually live longer than those who are not getting palliative care. You take the same type of patients with, let's say, a particular type of cancer, and they're both getting treatment to try to cure the cancer. One's getting palliative care, and the other is not. The ones that are getting palliative care actually live longer. So how do we move to palliative care? You don't have to say the D word, death or dying, for people to get good palliative care. As the people are talking about, thinking about hospice and palliative care, emphasize the positive benefits, the in-home support, the multiple discipline approach, spiritual support, financial support, all those types of things, rather than giving up on medical care. And lastly, always remind the patient and family of the goal of preparing for a comfortable and dignified death. So let me end up just saying a few things about the emotional, spiritual issues at the end of life. Let me show you one cartoon. This actually, as you can see, was from 1994. He was with Buffalo, then he's now the editorial cartoonist for the Washington Post. But here we have a doctor and a patient says, "Please let me die," and he has artificial blood, artificial stomach, artificial heart, artificial lungs, artificial liver, and the patient says, "Please let me die," and the doc says, "What? And play God?" I don't know. Why is it always, especially I've observed that the ventilators tend to attract the name of God more than any other device. And, you talk about taking somebody off a ventilator. So we can't make that decision. Only God can decide that. And I came up with a theorem about that, and that is the frequency of the invocation of the name of God is directly proportional to the amount of non-beneficial, aggressive medical intervention. Now, I've thought about saying to some of these families, "Oh, we can't do this. Only God can decide when somebody dies." I got an idea. Let's turn the machine off and see what God does. I never say that to someone because I really don't think they have a theological problem. They don't want this person to die. They haven't done the grief work of saying goodbye to these patients at the end of life. So it's not really a religion problem. It's an emotional, spiritual problem. I'm not going to have time to go into all of these. These are things that I've observed over the years and the research to back up these things too. But I would, a longer presentation would go into all of these, and that is, here are some of the things that issues they to deal with, emotional, spiritual issues. Seeking forgiveness and reconciliation, gaining a sense of what has happened to me is okay. Just letting things be. Gaining a sense of being part of a greater whole, often expressed as living beyond death. And people who don't believe that they're going to heaven or believe in life after death can have very peaceful deaths. You don't have to believe that to have a peaceful death. This actually was something new for me as I got into healthcare. I wanted, religious people to do dying better than non-religious people, and I never found any evidence that there was one did it better than the other. Coming to terms with the denial of death, letting go of all I've worked for over a life, the possessions, career, family, even letting go of this ego, of this self that I've created. And finally, of the spiritual issues and emotional issues, is coming to terms with the loss of control. Let me just give this quote and then close with a poem that I've put together. Flannery O'Connor, I happen to be in Georgia right now as I'm speaking to you, and she was born and raised in Savannah, and then moved in her teenage years to a farm outside of Milledgeville, Georgia. Southern writer, also known as a Catholic writer, very spiritual person. But she got lupus, and she had it for the last 13 years of her life. And she said this: "I have never been anywhere but sick. In a sense, sickness is a place more instructive than a long trip to Europe. And it's a place always where there's no company, where no one can follow. Sickness before death is a very appropriate thing. And I think those who don't have it miss one of God's mercies." Now, I don't say that to people. I've heard many people say that. But I can let Flannery O'Connor say it because she lived that out. Years ago, during the AIDS, when everybody was dying with AIDS, a friend of mine who had an AIDS patient, she was a psychotherapist, said one of her patients told her, "I finally learned the difference between giving up and letting go." And I thought a lot about that, and I started this poem, Giving Up and Letting Go, and then I added another a phrase to each stanza on letting be, and it goes like this. Giving up implies a struggle. Letting go implies a partnership. Letting be implies, in reality, there is nothing that separates. Giving up says there's something to lose. Letting go says there's something to gain. Letting be says it doesn't matter. Giving up dreads the future. Letting go looks forward to the future. Letting be accepts the present as the only moment I ever have. Giving up lives out of fear. Letting go lives out of grace and trust. Letting be just lives. Giving up is defeat at the hands of suffering. Letting go is victory over suffering. Letting be knows suffering is often in my own mind in the first place. Giving up is unwillingly yielding control to forces beyond myself. Letting go is choosing to yield to forces beyond myself. Letting be acknowledges that control and choices can be illusions. Giving up believes that God is to be feared. Letting go trusts in God to care for me. Letting be never asks the question. And I thank you for your time, and I wish you all the best in your ministry to people at the end of their lives. Thank you, Dr. Thomas.
That was an absolutely wonderful presentation. I can't thank you enough for the wonderful information that you've provided for us. We only have 1 minute left. I did want to ask you a question about substituted judgment and how it affects those who have to make that substituted judgment. Do you have any comments about that, or do you know of any research that's been done on that?
How to help families make that?
Well, when families have been placed in the position of having to make that substituted judgment, do we have any studies that demonstrate how it has affected them long range, or any comments about it whatsoever?
Yeah. Well, actually, the slides I had about my theorem, it is helpful if families have had conversations with the patient about what they might have wanted done or what they thought about their condition. One way to get at that, if they haven't ever really said, I would not want to be on a ventilator, but maybe they were caregivers for someone else, a spouse perhaps, or they observed. My father, one of his sisters languished in a nursing home for years with a feeding tube, and he was very clear he didn't want to have a feeding tube, and so because of what he observed that his sister went through, so of helping families if they can work on what judgment the patient might have about their particular condition would be helpful.
Okay. Well, again, thank you so much for a really wonderful presentation. I do hope that if we do have any questions, would you mind if we forwarded them to you?
Oh, please do. Yeah, send them my email, and I'll send them back to you. So.
Okay, that would be great. Thank you also very much for joining us for our clinical grand rounds, and that ends our conference for today. Thank you.
Thank you.